Hello everybody, this is Eddy Lugo from Brandon Pain Treatment Center. You can find us on Facebook and soon at brandonptc.com. Today I'd like to talk to you about lower limb length inequality, or leg length inequality as some might say, and how we assess that and why it's important and how we treat it as well. In discussing leg length inequality, I'm going to make some claims that either come from case reports or actual studies. And instead of getting into those details in the video, I'll put a link where you guys can look that up to get more information. In different practices, people will refer to lower limb length inequality as functional or structural. We don't make that kind of a distinction. For us, a functional leg length inequality really just means not really that one leg is shorter than the other, it's that there's a hip tilt, or the hip is either anterior or it's oblique. There's some muscle spasm that's probably causing what looks like a leg length inequality. When we talk about leg length inequality, we're actually talking about structural leg length inequality. That is to say, either one femur is shorter than the other femur, or one tibia is shorter than the other tibia. So we distinguish from functional and structural. For us, functional leg length inequality simply means that there's some distortion in the hips caused by muscle spasm. So part of the reason why leg length inequality is significant is because it's associated with pain symptoms such as low back pain, sciatic nerve pain, hip pain, and scoliosis. Why is that? That is because we have something called the writing reflex. That is to say that our cranium has to be level. Our eyes and our ears have to agree. Our cranium has to be level. Otherwise, we feel off balance. We feel like we're not quite right in the space around us. We might get dizzy spells. We might become cumbersome because of that. So the body has to try to accommodate one leg being shorter than the other. And how is it going to do that? Well, one of the most immediate ways it's going to do that is by tilting the hips. So if one leg is shorter than the other, the body might try to tilt the hip in the opposite direction. How does it do that? It does that with the glutes and the low back muscles, for example. And as your body has trouble accommodating, trouble fighting that tilt in the hip, those muscles will start to spasm. And very often that is why you have low back pain. Over a long period of time, that actually will cause compression on the joints, especially the hip joint, and that actually may eventually turn into arthritis. It may turn into inflammation. It may even be the cause of the need for a hip replacement. Our work can actually stop the destructive process that might ultimately lead to a hip replacement. We might be able to stop that process. In young people, as they grow, part of the evidence that we see about lifting young people in particular is that if we don't put a lift in at all, the leg length inequality will either stay the same or possibly even get worse. As a young person is going through those growth spurts and the body is trying to accommodate one leg being shorter than the other, part of that accommodation might actually be in the spine. It might cause a curve in the spine. So as a child tilts in one direction, their body's not going to fall over that way. The spine's going to curve in the opposite direction, and then the neck has to curve back, and that's what we call classically, of course, scoliosis. So by correcting especially a young person, putting them in a full foot lift and doing the muscle work, we can better straighten the spinal curve of scoliosis. I want to stress that even a small leg length inequality, 2, 3, 4 millimeters, can actually cause a substantial amount of pain over a long period of time. If you imagine a difference of just 2 millimeters at the feet, and you follow that distortion up to the cranium, that little deviation of 2 millimeters gets larger and larger and larger and larger as you get to the head. So the head may be wagging out to the side just because of a small leg length inequality. Your body can't tolerate that. Your body will not tolerate you wagging out to the side. It's going to fight and try to get you back to center that way. So over many years of your body trying to accommodate even that small leg length inequality, you may still experience neck pain and back pain, even hip pain and knee pain from your body trying to accommodate that relatively small leg length inequality. So we assess for leg length inequality perhaps a little differently than most people are used to, which you typically see in a clinic or in videos on YouTube, for example. There have been studies made on the different kinds of assessments for leg length inequality as well, and we use a system that uses an X-ray, and the body is set up a certain way so that X-ray comes out very accurate. It's actually been proven to be very reliable and very accurate. So we start with the visual approximation. We measure visually at standing at the greater trochanters, and we try to see if one is lower than the other. To try to make that measurement more accurate, we will push the hips up against the wall to get rid of any rotation. We'll make sure that the knees are on the same plane, and if the patient needs arch supports, that they're measured actually in arch supports. So a low arch doesn't make it look like they have one leg shorter than the other. And then we check at the greater trochanters, and we might see that one is lower than the other. And that is a weight-bearing way of trying to see whether there's a leg length inequality. We also do a non-weight-bearing assessment on the table. We measure at the greater trochanters to see if one is superior or inferior. Then we measure at the tibial tuberosity to see if one is superior or inferior. And then we check the heel pads as well. Traditionally, what is done with a tape measure, if you've seen this technique, is they measure from the ASIS, from the hip down to the heel pad, and then they compare those left and right legs, and they'll say one might look shorter than the other. Another way that is done is from the belly button to the heel pad. Neither one of those is very accurate at all. Again, you can check the study that I'm going to refer to in just a moment here. So they're not reliable and they're not accurate. Also, they're not actually measuring the length of the leg. If you're measuring from the ASIS to the heel pad, you're actually measuring the position of the hip to the leg. From the belly button to the heel pad, again, position of the waist to the leg. If you have, for example, an obliquity, where your hips are doing this, they're oblique. The belly button is going to be closer to the left leg than it is to the right. It's not an accurate way of measuring leg length inequality. So we visually assess it by looking at those three bone positions, greater trochanters, tibial tuberosity, and then the heel, and that gives us a much better estimate, a visual estimate of whether we think someone might have a leg length inequality. If it does seem that a patient has leg length inequality, even a small leg length inequality, we will send them to get an X-ray to confirm that. The X-ray, again, the accuracy of the X-ray has to do with a certain procedure that we didn't invent, that was actually invented by Dr. Travell. And she devised a way, using an X-ray at the hip, level of the hip, to very accurately measure leg length inequality, and that's the system that we use. So once we have confirmation from the X-ray that a patient actually has one leg shorter than the other, that the bones are a different length, the treatment protocol that we have is that first we put them in a full foot lift. It's important to put a patient in a full foot lift because if you just put a patient in a heel lift, the way often chiropractors and podiatrists do, what that does is it makes the heel on one side higher, in other words. That causes a correlating hip flexion on that same side. So by putting in just a heel lift in one foot, you're actually causing the hip to flex in one side. So you're solving one problem and causing another. So we prefer to put our patients in a full foot lift to lift the entire foot up so that we make the lengths of the legs equal. There are times when we put our patients into a full foot lift and they feel worse. That is called rebound accommodation. We try to avoid that by sometimes lifting them slowly. If someone needs, for example, 15 millimeters, I will actually look at the X-ray and take a look at the SI joint and the sacrum, the position of the sacrum, and I'll try to decide how high of a lift I should put that person in right away. If their sacrum is very tilted, equal to the hip in particular, they'll feel great probably in a full lift. If their sacrum is not as tilted as the hip is because of the leg length inequality, then they may not feel very good in a full lift. So if someone needs, let's say 15 millimeters, I might start them at 8 or 10 millimeters, work on them, measure them, and then build them up 2 millimeters at a time so that they can better accommodate that full lift. A really exciting aspect of treating leg length inequality this way, assessing it and then treating it with a full foot lift and then doing the muscle work that's necessary, is that there is very strong evidence that shows that if you lift a child that has a leg length inequality before they're 25 years old, in other words, before they've completely grown, that they actually may grow some of that bone back. And not only is there evidence of that in a 25-year study, I've actually had that experience as well. I have a young patient who's 15 years old, and we caught him just in time. He had a 10 millimeter length inequality, and within 10 months he had a pretty major growth spurt. He's a tall kid, and he was religious about putting that lift in. He said he always had that lift in, whether he was at home or at school or wherever he was always in a lift. And in only 10 months, he went from 10 millimeters to 4 millimeters in leg length inequality. A really exciting, a really amazing case. Well, I hope that was helpful in answering any questions you might have about leg length inequality. I welcome any comments or questions that you might have. Also, if you have any suggestions for future videos, that would be great if you would leave them in the comment section. In 2 weeks, Melinda is going to post a video about how nurse somatic therapists treat the viscera, how we treat organs. It's fascinating work. We have amazing success treating not only pain associated with the organs, but pain you might not have thought was associated with the organs, including low back pain as well. So come see us in 2 weeks. Take care.